Hi, my name is Dr. Brähler. I'm a clinical psychologist and seasoned teacher and trainer of compassion-based approaches. And this video is for you if you are a colleague and you want to boost your therapy and your natural way of working by bringing in some self-compassion, but maybe not having to work so hard. So I promise that what I will share today does not involve you having to read yet more books and take more courses, but will help you straight away, will be something you can do in your therapy session straight away by simply paying closer attention to the relationship that you have with yourself when you're with a client, the relationship that you have with your client, and the relationship that your client has with him or herself. So let's start. For everyone who's not familiar with self-compassion, one way of defining it is that it refers to a kind, wise, and unconditionally supportive relationship with myself when I'm feeling bad or I don't like myself. So when I'm suffering, no matter how big or small. So this is one way of defining self-compassion. Now, we know from research that this relationship, if this relationship is present in clients at the end of therapy, it goes along with reduced symptoms compared to clients who have lower self-compassion at the end of therapy. And this has been found irrespective of the kind of therapy that was used. And all these therapies did not focus on the cultivation of self-compassion. So this seems to suggest that self-compassion is a core mechanism of change in many therapies, maybe in all therapy or in all kind of inner development, personal development, that is implicitly at play and could even be an indicator of successful therapy. Because as a therapist, wouldn't we be really happy to know that at the end, that all the gains are maintained even a year down the line, because our client can really tune in to how they're feeling, they're noticing it, they're warmly validating everything that they're feeling, and they're giving themselves exactly what they need in that moment in a wise and kind way. Also, if the client had attachment issues, shame issues that made it difficult to develop a secure therapeutic relationship, knowing that they have this self-compassionate relationship at the end of therapy is an indicator that they've really internalized this secure therapeutic relationship that we've developed with them over time. So really we can assume, I guess, based on the studies that we have to date, that self-compassion is a core mechanism of change in psychotherapy and possibly in other kind of healing modalities and other types of personal development. So, if you just picture a session with your client, how can you enhance your therapy through compassion for yourself and others? So let's start by focusing on yourself. How are you in the room? So what is the relationship like that you have with your suffering self or the suffering parts? So how are you doing? Is there any distress, discomfort, worries? And how are you relating to them? How are you feeling towards them? If the answer is, they're annoying me, I want them to go away, or you're being sucked into them, you kind of over-identify, which, by the way, is the normal human response of our threat system, the standard response, then of course you're not being terribly compassionate with yourself. So what that does, though, is that when you're with your clients, you're kind of embodying this degree of stress that is unattended to. And you have to kind of put it to the side, and that's actually an act of violence against ourselves. So what's really important to help us also embody, what we teach and walk the talk, not just talk the talk, is to simply take a short break between clients and tend to that distress. Validate it, acknowledge it, and ask yourself what you need. And there are some very simple guided meditations that you can download for free, link below, to do that. And we know that there are studies that show, there's one study that shows that if therapists take 10 to 15 minutes at the start of their day to tend to themselves and be with themselves, their therapies are more effective. Their clients have reduced symptoms compared to therapists who do not take that time. That's a very small investment. Of course, we often have these inner parts that are feel excessive responsibility for others, sort of caregiver parts that are driven by fear often, and they often then have fears attached to them of being seen as selfish, if we even tend to ourselves for a second. But really trust that this is an investment that pays off for yourself, for your own well-being in the long term, and also for your clients. So this is something you can do straight away. Now let's move on to the second level of relationship, which is the relationship that you have with your client. And you may know this, or you may remember this when you were a novice therapist, that often we get so caught up in mastering the protocol that we're learning, or the therapeutic model and the interventions, and applying them correctly, which is so very important. But that we forget that actually the relationship makes up the largest part of also the effectiveness of therapy. This is what studies show time and again, and important, especially that the client feels felt by us, right? So, and often we can even ask ourselves, how am I applying this intervention or this protocol? What's driving me? And sometimes we can tell there is another part in the driver's seat that is either striving, or the caregiver, the rescuing part that is very worried, or it's something to do with our own ego, that we want to prove to ourselves that we're effective, or to others. So anyhow, we can ask that question, what do I feel towards my client? And what part of me is driving this intervention, how I'm kind of offering it up or implementing it. Okay, so that we really also take into account the sort of the attitude of the relationship. So what's compassion got to do with it? So I'm going to mention a taboo now, which I think is still a taboo, which is that in our work, or in any helping profession, where we're faced with the pain of another, emotional or physical, day in, day out, it is normal to feel exhausted, or to feel numb, or frustrated, irritated by our clients, and also often powerless or clueless. So I want to briefly explain why this happens, so that you don't feel like, oh God, she's found me out, I'm the only one. No, you're not. So by default, our social brain feels the suffering, the pain of another when we're with another who's suffering. It's like a mirroring. This is the default setting of our social brain when we're with somebody who suffers. So this has been known for a good decade now, and it's called empathy pain, or empathic distress. So naturally, I want to make the pain go away. I've got threat reflexes, right? Fight, flight, freeze. So I'm distressed because of your distress. So I'm going to make your pain go away, or make the person go away who has the pain, so that I don't feel the pain. Okay? So these reactions that I've just described are simply a consequence of this empathic distress. If you want to know more about this, the neuroscience behind it, and also how to regulate it, please watch my animation called Empathic Pain versus Compassion. Now, so again, we can obviously use self-compassion, these very simple methods, just a couple of minutes. You maybe even don't need to use them, you just need the awareness to attend to this empathic pain, like I just taught you to attend to any small distress that you may be having, and take a couple of minutes, maybe just some seconds, to validate and soothe it. So we do the same because we're suffering with, it's not our fault, and we switch perspective. We ground ourselves in our body. We realize, okay, this is just a minute ago I was fine. Now then I stepped into the room and I obviously now feel bad. This is obviously coming from the other person, so I'm okay. It's coming from them, and we switch on our wise perspective on the suffering. And if we lose that perspective, it's often because we feel excessive amount of responsibility, or we are clueless. We expect ourselves to fix it. We fix something that isn't within our power to be fixed, or only a very small aspect of that. So what you find linked below are two things. One is a very brief meditation that you can do to sort of offer yourself compassion when you're experiencing empathy pain, and then move into compassion for the other, literally whilst you're in session. So you can do that maybe once or twice on your own, and then you can do it in session naturally without having to close your eyes. Very easy to implement. But also there's a worksheet which can help you to switch on your wise mind and adopt a more balanced, realistic, wise perspective on the situation. Because no, it's not completely within our power to fix it or to save them or whatever, right? So this creates huge amount of stress, but yet there is something that we can do, but what is it? And so having that wise perspective and the compassion for ourselves, soothing ourselves so that we're again have positive affect for the other person, allows us to be there, to stay there, to hold space and trust that simply by being there, not running away, in this atmosphere of goodwill and warmth and trust, and I may even say love in the widest sense of the word, it provides a healing space. And that's our job primarily. And we can, bring out all our cool interventions and techniques as and when is needed, because we're ready to respond in the way that is needed and support the person, right? But primarily we need to set up this holding space within which we can then apply any of those techniques or interventions. So now we're moving on to the relationship that the client has with him or herself, to focus on that. So, often I get asked, when should you add an explicit focus on self-compassion to your therapy? For whom is this suitable? So everything I've just said up to this point applies to any helping profession, to any kind of therapeutic relationship that we have. I would argue, to ensure we don't get burnt out, to ensure we enjoy our jobs, to ensure we actually create a safe, effective holding space and healing space for another. Now, what I tend to say is that when I notice how the client relates to themselves, and I hear a lot of harsh self-judgment, self-criticism, I either hear it in how they talk to themselves, or I observe it in how they treat themselves through their behaviors that are evidently showing that they're being very harsh on themselves and possibly hurtful. And also neglectful. So I watch out for neglect, self-neglect, like not even taking your own needs seriously, your own emotions. Not even knowing what care feels like, yet really needing it, and obviously having neglected parts. And I guess shame and its compensations. This is a bit more difficult, and I have more offerings on that to help you understand shame and its compensations and how to work with it. But I guess it starts also with us being aware of our own shame issues and our compensations. That helps to also detect not so obvious shame in our clients. But of course, often when they come to us, the compensations no longer work and there is strong shame present. So we know that shame and harsh self-criticism and also self-neglect, they are sort of transdiagnostic mechanisms of illness, right? We find them in all kinds of mental illness, and they contribute to the causes, and they maintain the illness. So again, we don't need to fixate on specific diagnostic criteria. We can just look out for these transdiagnostic mechanisms. So you might want to add explicit self-compassion to your treatment plan. This completely depends on the kind of formulation that you have and the other capacities and abilities and needs that the client has. So it's very highly individualized. But what I want to highlight just now are a few things to consider and that I've observed over the years. So number one is that you have to remember that when we receive unconditional love and compassion from a therapist, or we are invited to give it to ourselves, we uncover the conditions under which we were not loved, or maybe abused or neglected or experienced traumatic loss. So this is something that we need to be prepared for and make sure that we help the client to access self-compassion in a safe way that does not trigger the threat system, that does not trigger these traumatic experiences, but instead only activates the care system. And what's also very important is to be willing to dose the compassion. So sometimes we can get very enthusiastic. Maybe we've had really positive experiences with self-compassion and it's really helped us maybe to, step out of these draining caregiver parts and the excessive responsibility for others. And we're like, finally, I've kind of given myself permission to tend to myself and, not feel shame around having needs. And I feel more like, I can be more of myself. And this being human actually helps my clients and, which is wonderful. It really, really is an amazing resource. However, we need at that point be very cautious to remind ourselves that our attachment conditioning and our conditioning of our care system is completely different from the conditioning of our clients, each individual client. And it can trigger adverse reactions because it can simply trigger memories of not being cared for, of being neglected, of being abused. And so there are a few tips and tricks that I've combined into a course. So now I'm advertising a course, I'm very well aware of that, which is called Self-Compassion Psychotherapy. And in module 3, you can learn there are tools to help you find these safe access points and design very individualized protocols, if you like, for each client to make sure you do it in a safe way. But I'm already going to give you some key principles for doing that. So if you're not too familiar with self-compassion, this may be confusing, but I'll mention that anyway. Maybe you'll come back to it at a later point. I call them the 3 Ds. So the first D is for desensitization to the experience of care and compassion. So we don't want to overdose. So we want to find safe access to this felt sense of compassion and then gradually maybe increase it so that this muscle grows in the person, that they know it's safe and it doesn't activate the threat system, right? So we're growing in the sense of warmth and kindness and care, and we're okay. We're getting used to receiving it from another, to maybe giving it to another, and ultimately giving it to ourselves. So the second D refers to direction. So compassion and care is something that we receive from another as children. We're dependent on it for our survival, right? So it's a relational experience. And we, as a therapist, can see in which direction does the care and kindness flow most easily for the client. Where do they receive it most easily, or also give it, so experience it most easily, without it triggering the threat system. And they feel kind of maybe even empowered by it. And it's a strengthening experience. And this can include us giving it to them if they have no template for a caring, kind relationship. And this is really important, that we're also willing to be the compassionate other for them until they're able to imagine or experience other kind of kind relationships, either from them to another or from another to them, or even observing others and feeling what that does with them. So, and these can be real people or animals or imaginary ones, past and present. So we can get very creative with that. You'll find more information in Module 3 to help you design these individualized interventions. The third D stands for differentiation. What I mean by that is who needs what from whom. So we don't want to simply pour some pink sort of sugar coating onto our pain or the pain of our clients. We really always need to tune in and feel some of the pain to know what the medicine is that it needs, right? We're not going to get stuck in the pain or sucked in to it, which is unfortunately our default setting in many ways. We want to hold it and alleviate it with just the right medicine. So if I'm feeling sad from a loss and there's grief, I need comfort. If I feel intense shame for being ostracized, then I want to feel like I belong and that I'm worthy, right? That I'm loved. If my boundaries have been violated and there's a great sense of injustice, I need to feel empowered to stand up for myself or protect myself in some way or another. So who needs what from whom is kind of the question that then comes up if we're working with parts, if they're showing up, and we then bring compassion and a specific quality of care and compassion to these individual parts, which many of you are already doing if you're doing parts work with your clients. So it's simply about adding the focus on the quality of care and compassion that is being offered, rather than simply using a word like compassion and saying, what do you actually mean by that? So we actually don't use the word compassion. You would just say, what does this part need from the other? Well, it needs to know that it's, that it's loved, or that it's protected, or whatever it might be. And also differentiation refers to the level of mentalizing capacity. So sometimes our clients struggle to mentalize, which is to reflect on their own mental states and to, infer and so forth. So we can adjust these, all these interventions, all these methods to suit and fit the client's mentalizing capacity, because, we don't want to make them feel inadequate, and there's wonderful ways to do that same work in the here and now in a very concrete, visible way, instead of being very abstract and internal and intrapsychic and so forth. So I've given you some tips. I think to summarize, it's really important to know that it's okay to be, or it's wonderful actually, to be a human being, So be a person first, maybe in therapy, and only in the second instance a role. And please, I invite you to appreciate your humanity as a wonderful resource in therapy. Again, I think it's an interesting exploration to ask the question, why not replace us with humanoid robots? Because it takes me anyway to this uniqueness of my humanity, my knowing what it feels like to be a human in this body of flesh that is impermanent and often hurts and get sick and will die, and the compassion that I need to develop, the heart that I need to develop for myself to, be okay with this human condition and to even rejoice in it, and the joys that this comes through being embodied in this human life. And to share that with others, the common humanity that emerges from them, I think is priceless and one of the best antidotes to shame. So I invite you to reflect on that. And again, also remember our attachment past determines our compassion present. So just be very open, very observing of how your clients respond to all this, and feel free to get creative and adapt it. Less is more. Teach what is within you, not as it applies to you, but as it applies to the person in front of you. So if you need help with that, please check out Module 3 of my course, Self-Compassion in Psychotherapy. And of course, you can dive into Module 1 and 2, which help us really be present with our clients and also troubleshoot challenging situations in the therapeutic relationship in Module 2. And you can check out my book chapters and other free resources down below. And please share this with a colleague if you found it helpful. Have a conversation around it, a de-shaming conversation, and hopefully it's not caused you any stress. And maybe it's simply validated you in what you're doing already. So wonderful, keep going, and hopefully see you again soon.